Hello and welcome to our webinar. My name is Tracy Cook with Sachs Healthcare Communications. I'd like to show our audience how you can send in questions throughout the webinar. Our speaker will try and answer as many as possible at the end of the presentation. You can type your questions into the questions box on the GoToWebinar control panel and also download the handout in the handout section. I'd like to introduce our moderator today, Lexi Caraway. Lexi is currently the cardiopulmonary manager at Clay County Hospital in Flora, Illinois, and a senior patient trainer for Baxter. Lexi is a member of the Illinois Society for Respiratory Care Board of Directors, currently serving as delegate and as Illinois PACT co-chair. Lexi has published several abstracts for the AARC Open Forum, including a study titled Telemedicine, Improving Quality Metrics in a Rural Community Hospital. She has presented at several state and national respiratory care conferences. Lexi, welcome.
Thank you, Tracy, for that kind introduction. The title of our webinar today is The New VAP Prevention Guidelines and the Importance of Oral Care. Speaking on this very timely topic is my colleague and one of the experts on the topic, Gail Drescher. Gail is currently a science writer at international consulting firm and the technical editor for the American Association for Respiratory Care Journal. Additionally, Gail is a clinical specialist at Washington Hospital Center, Washington, D.C., where she is involved with research, program development, and process improvement. She has published extensively in several peer-reviewed journals and has lectured frequently at regional and national conferences. Recently, Gail has been awarded the Charles W. Serby COPD Research Fellowship Award with the American Respiratory Care Foundation. The speaker has disclosed no financial relationships associated with this presentation. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of the webinar. The accreditation statement is below. This activity is supported by an education grant from Dale Medical Products, Incorporated. Now I will turn the presentation over to my friend and colleague, Gail Drescher.
Thank you so much, Lexi, for that very kind introduction from me. Today, we're going to discuss the new VAP prevention guidelines and the importance of oral care. We're going to define and describe ventilator-associated events in pneumonia, just so we have a little background of the terminology that we're going to be talking about. We're going to describe the evidence from the updated 2022 guidelines on the prevention of VAPs and the supporting recommendations for oral care. We're going to describe the risk factors related to problems with oral care and the development of VAP. We'll describe methods for reducing oral microbiologic load in mechanically ventilated patients, and then we'll discuss the role of oral care protocols in the prevention of VAP. First, I wanted to define ventilator-associated events and ventilator-associated pneumonia and talk a little bit about their frequency of occurrence. So VAP rates in general have been stable between 2005 and 2013 as reported by the CDC. In the updated 2022 guidelines, they report a rate of ventilator-associated events, which is VAEs, of between 5 and 10%, and ventilator-associated pneumonia also between 5 and 10%. That CDC data, though, shows that ventilator-associated events declined in 2021 to 2022 by 18%, and non-ICU events between 2021 and 2022. And a lot of that may be related to the pandemic, so pandemic-related changes. VAP rates and mortalities, so studies show that VAP has one of the highest morbidity and mortality rates of all hospital-associated infections. I think there are a few that might be ahead of it. CLABSI, CAUDI, might be slightly ahead in terms of frequency, but I think VAP has probably the highest mortality. So ventilated patients are about 3 to 10 times more likely to develop healthcare acquired pneumonia or nosocomial pneumonia compared to non-vented patients. And the highest risk for this development starts within the first 48 hours, which is a little bit interesting because the CDC really doesn't start to define VAP until after the 48-hour mark, mostly because they don't want to include patients that maybe had pneumonia as the cause of intubation. So about 60% of all deaths from hospital-associated infections in the US are due to VAP. It increases ICU as well as hospital length of stay, and it costs a lot of money. And so different studies report different things. In the 2022 guidelines, mortality rate was reported upwards of 33%. So the CDC has developed a hierarchy to try to standardize the definition of various ventilator-associated events, including ventilator-associated complications, infection-related ventilator-associated complications, and possible ventilator-associated pneumonia. And by standardizing, they're hoping to kind of take out some of the uncertainty as to whether a patient has ventilator-associated pneumonia or not. So you have your clinical, you have your radiographic, and then you have your microbiologic criteria for VAP. When we look at ventilator-associated events over here, basically the patient is having problems with worsening oxygenation, and that is demonstrated by an increase in PEEP greater than 3, sustained for more than 2 days, after 2 days of stable or decreasing PEEP, or the need for a greater FiO2. Infection-related ventilator-associated complications are indicating that there is a possible infection through clinical signs or laboratory data, including temp, white blood cell counts, or the patient has required an antibiotic for greater than or equal to 4 days. And then last but not least, we come to our VAP, which is an infection-related ventilator-associated conditions with some indication that it might be localized to the lung. So the patient may have had worsening oxygenation. They may be demonstrating a temp and increased white blood cell count. And now we've gotten imaging, either a chest X-ray or a chest CT, that is showing an infiltrate on this diagnostic test. But we've also obtained microbiologic cultures. Maybe we've got a sputum sample, or we got a protected specimen brush, and that is coming back positive for some type of infection. And so again, having these standardized definitions helps to improve the accuracy and variability of diagnoses across institutions. And I believe the National Healthcare Safety Network is still collecting this data, so they're not really collecting data necessarily on VAP. Now, this is different than the Agency for Healthcare Research and Quality, which I believe has changed now under the new administration, but the collection of this specific data still continues within the federal government in order to sort of track very important healthcare outcomes. So the adverse events associated with, excuse me, I went too far. The adverse events that are associated with ventilator associated events are significant. So increased duration of mechanical ventilation, ICU and hospital length of stay, as we mentioned before, increased use of antimicrobials, and we know antimicrobial stewardship is a big push among healthcare providers, and then increased mortality, with some studies showing mortality upwards of 50% in certain patient populations. And there are very specific calculations for these different events, ventilator-associated events, infection-related ventilator-associated complications, and VAP, that involve total vent days. Sometimes it's difficult to get this data. I know I've tried to get this data from my hospital, and really getting the denominator of total vent days has been difficult just because of SQL coding, and then ICD-10 codes don't seem to be sufficient. So it's actually been very difficult for me to track our actual VAP rates within our hospital. So the risk factors for the development of VAP include sedatives and opioids. Oftentimes extensive use of these keep a patient on a vent longer. The longer you're on the vent, the more likely you are to develop VAP. Fluid balance, positive fluid balance can delay weaning and provide an environment for the microbes to grow. Mandatory modes of ventilation also keep a patient on the vent longer. You might get diaphragmatic atrophy because the patient isn't using their diaphragm. Blood transfusions, which can cause a relative state of immunosuppression. Oral care is the one that we're going to discuss today. Stress ulcer prophylaxis because it decreases stomach pH, increases stomach pH, which then allows microbes to grow. Patient transport, which kind of jiggles the patient a little bit and may allow more leak around the cuff. Gastric retention increases the risk of aspiration. Reintubation, which once again bypasses the patient's airway defenses. And neuromuscular blocking agents, which again are associated with prolonged invasive ventilation. So right now we're going to discuss the strategies to prevent ventilator-associated pneumonia, that update from 2022. So this document provided practical recommendations for acute care hospitals that they hoped would be prioritized and then implemented in order to prevent VAP. And so they were really trying to look at studies that had important clinical outcomes, both for the hospital and for the patient. It would be important to the patient to reduce duration of ventilation, ICU and hospital length of stay. Of course, it's very important to the patient and the hospital to reduce patient mortality, as well as ventilator-associated events and antibiotic use. So all of these studies were chosen because they had an important impact on one of these clinical outcomes. And based on that level of evidence and which of these clinical outcomes it influenced, they made their recommendations. So these recommendations were categorized as either essential practices or additional approaches. So some of the essential practices include use of high flow nasal cannula or non-invasive ventilation, and that's because this prevents reintubation. Minimizing sedation, which I think we've already discussed, to try to reduce length of invasive ventilation or duration of invasive ventilation. Early mobilization for strength, elevating the head of the bed for aspiration, and then oral care with toothbrushing with the quality of evidence moderate, which we're going to discuss a lot about that in some of the coming slides. Enteral nutrition to maintain the gut, and maintaining ventilator circuits. By breaking the circuit, you allow the entry of potential pathogens or microbes. The additional approaches included selective decontamination of the oropharynx and the GI tract. And we'll also do some discussion of that as well in the coming slides. So now we're going to look at risk factors for VAP related to oral care and some of the evidence surrounding that. One of the biggest studies that was used in the 2022 guidelines for the recommendations came from the Cochrane Library. The Cochrane collaboration, it's an international not-for-profit that specializes in creating meta-analyses for very important healthcare-related questions. And so this meta-analysis was oral hygiene care for critically ill patients to prevent VAP. And I just want to briefly review what a meta-analysis is. It's a statistical method of combining a variety of studies that look at the same outcome. You can get a larger sample size, which can increase the validity and reliability of your effect size. It can help resolve any conflicting study results where one study shows that it helps and another study shows that it doesn't. Some of the limitations include heterogeneity. So basically what heterogeneity means is that you have different study results between your randomized controlled trials. And so more differences in these study results usually means you have higher heterogeneity. And that difference might come from difference in methods, different in populations, as well as differences in really the comparators as well. And then real quick review of our forest plot. So each of those lines represents a study. The box in the middle of the line represents the sample. Usually the bigger the box, the bigger the study sample. Um, if any of those lines cross that center line at 1, it means there's no difference. So that confidence interval, they're saying, well, we're 95% certain that the true value lies somewhere within that confidence interval. And if that confidence interval crosses 1, it means, well, we're 95% certain that, the confidence interval is showing that there actually is no difference between studies. And then at the very bottom, you have your overall effect, which is combining all of those studies to give us a measure of, well, how well does this treatment work? And it's great to have a p-value, I always say, but you really want the effect size. How much of a difference does this treatment work? And we're going to be taking a look at that now. So this Cochrane review had 40 studies, 37 for the meta-analysis. And they looked at a variety of questions. The first was toothbrushing versus no toothbrushing for the outcome of VAP. But what you'll notice here is that they looked at toothbrushing plus or minus the use of chlorhexidine in several of these subtotals here. So both the first and second subtotal, and then they looked at toothbrushing with povidone iodine as well. And so overall, they did find that toothbrushing decreases the incidence of VAP. The relative risk was 0.61, meaning that it's going to reduce the incidence of VAP if you use these techniques by about 40%. The problem with interpreting this is because they looked at toothbrushing combined with some other tactics like chlorhexidine or like povidone iodine. Next, they looked at mortality, toothbrushing versus no toothbrushing on mortality, and they found no mortality benefit. But again, notice that toothbrushing was combined with a variety of other procedures. For ICU length of stay, toothbrushing did seem to make a difference, but again, it was combined with chlorhexidine versus chlorhexidine alone. That mean difference meant that patients would spend on average less than 2 days. So you took off 2 days from the ICU stay if you used these procedures of toothbrushing plus chlorhexidine. But the real money shot comes from chlorhexidine compared to placebo versus usual care. So they found no difference in VAP rates when they compared chlorhexidine solution versus placebo to toothbrushing. They also found no difference in VAP rates when they compared chlorhexidine gel versus placebo, which included toothbrushing. So in other words, chlorhexidine wasn't better, regardless of the form, a solution or a gel, than toothbrushing. And there was no difference in ICU length of stay comparing chlorhexidine versus usual care. And then usual care could have included toothbrushing, and in these top two, it did not include toothbrushing. Chlorhexidine and other agents for VAP, so chlorhexidine versus other topical antiseptic agents, really showed kind of a variety of results. Overall, when you combined all studies, there was no difference between chlorhexidine and other oral agents in the incidence of VAP. Some of the individual study clusters did show, maybe the control was a little bit better, but otherwise it wasn't showing that chlorhexidine was better than some of these other antiseptic techniques. And then we get to some studies that are looking at chlorhexidine and mortality outside of that meta-analysis through Cochrane. So this looked at chlorhexidine and the influence on hospital mortality. And this was a pretty big study involving over 82,000 patients with 11,000 having used chlorhexidine. And they stratified the patient by low and high levels of exposure to chlorhexidine. Low was less than 300 milligrams over the course of their intubation. High was considered greater than 300 milligrams, but they also adjusted for mortality risk as well. And what you're seeing here at the top, if you look at the risk of mortality over here, minor, moderate, and major, and then chlorhexidine exposure, what you'll see is that in high and low chlorhexidine exposure, mortality was greater versus patients who had no chlorhexidine exposure. And looking at some of these unadjusted results here, you can see, using minor as a reference, that moderate, major, and extreme risk of mortality was associated with really pretty increased risk of mortality when you combined the use of chlorhexidine in these patients by 7 times, 28 times, and 180 times. So these are very significant results showing that chlorhexidine levels and exposure, regardless of mortality category, can really increase death rates in these hospitalized patients. But the coral study actually kind of contradicted some of the other studies. This was done in over 3,200 patients in 6 ICUs in Canada. So they did a stepwise de-implementation plan of chlorhexidine with the adoption of standard oral care that included toothbrushing for IVAC prevention. So chlorhexidine was maintained until it was time for that particular ICU to de-adopt chlorhexidine and adopt standard oral care protocols. And if you look here at ICU mortality and IVAC group, you can see that there was no difference between the control and the intervention group on either mortality or the rates of IVAC. They did find that the Bose score, which is a measure of oral health, was actually lower in the intervention group, which would have been the adoption of standard oral care compared to the control group. Now, selective digestive and oropharyngeal decontamination has also been a method that has been studied and has been adopted in certain ICUs. This was a meta-analysis from 6 randomized controlled trials looking at selective digestive decontamination as well as selective oral decontamination. They did find better mortality compared to a control. Now, this was not compared to chlorhexidine, and unfortunately in this study, they really didn't define what usual care was. I believe that the goal in this study was to distinguish between medical and surgical patients to see if there was a difference in using these techniques between these patient populations. If you go to the top graph, selective digestive decontamination, you can see that there was a mortality benefit versus control with STD, and also the same with selective oral decontamination. So selective digestive decontamination reduced mortality by 18%, and selective oropharyngeal decontamination reduced it by 16%. If you go to the bottom of each of these graphs, you'll see the interaction. And basically what this means is that there was no difference between whether they were a medical or surgical patient, nor were there interactions by age and comorbidities or acuity. Now, this was a little bit better because it looked at selective decontamination versus chlorhexidine. And what you're seeing here in this forest plot, and remember we have all of our different studies. We want to see if they cross that line of 1, and if they cross that line of 1, it means they have no effect. But in doing this meta-analysis, we're combining all these studies and all these sample sizes to give us an effect size. So this is looking at the use of selective digestive decontamination, which consists of like a poorly absorbed topical antibiotic. So maybe it's colistin or tobramycin or amphotericin or something like that, something that's poorly absorbed in the oropharynx, as well as a gastric suspension and or systemic antibiotics as well. So they're looking at the effects of these three things on death in the general care intensive care unit. So here you can see STD was better than the control. Now, in this case, the control is not referencing chlorhexidine. They did a separate analysis comparing STD to chlorhexidine, and they found that mortality was almost 40% less when they used selective digestive decontamination versus chlorhexidine. Now, this is what I'm talking about, a meaningful effect size. If you say that you can reduce mortality by up to 40% versus chlorhexidine, that means something to our hospitalized patients. They also found a mortality benefit for selective oropharyngeal decontamination. But I will say that there was no data comparing selective digestive decontamination to toothbrushing for important clinical outcomes. And here is the data on selective oral decontamination. It reduced mortality by 33% compared to chlorhexidine. Selective oral decontamination is again topical antibiotics that are poorly absorbed in order to decrease the microbiological load of pathogenic organisms. But one of the things that they did find in this study that is significant is that chlorhexidine actually increased mortality when they looked at that by 1.25 times, 95% confidence interval between 1.05 and 1.5 times greater mortality in these patients. Now, this article by Klumpus has been cited quite a bit in terms of increased mortality. This was done in cardiac surgery patients. So randomized controlled trials through this systematic review and meta-analysis in mechanically ventilated adults. So this data also included not only VAP data, but it included data just on nosocomial pneumonia in general. And so they did find that there was a benefit in using chlorhexidine as compared to a placebo, which was just the inert comparator, in that healthcare-acquired pneumonia or nosocomial pneumonia dropped by 27%. But what they didn't find was a difference in VAP, a drop in mortality or duration of decrease in duration of ventilation or ICU length of stay. Now, numerically, they found an increase in mortality, but this was not statistically significant. So why are intubated patients at risk for ventilator-associated pneumonia? So we know that there is an association between oral health and various respiratory diseases. Oral colonization by respiratory pathogens that is fostered by poor oral hygiene does play a central role, and there's been a lot of studies that show that, as does impaired host defenses. And that's what we're seeing here. It's multifactorial, so secretion management, the intubation procedure itself, oropharyngeal and digestive tract bacterial growth, and then microaspiration and the artificial airway cuff. And we're going to take a look at each of these issues. So there is impaired saliva and swallowing once you intubate a patient. We know that there is natural or normal oral flora in a patient. And there's usually about 700 species of bacteria, fungi, protozoa within a patient. And there is a balance to that. And when that balance is thrown off, it's called dysbiosis. So typically in saliva, we have components that are antimicrobial. These include proteins like mucins that actually bind to the bacteria and keep the bacteria from adhering to the tooth or to the ET tube. We have lactoferrin, which actually binds to iron, which is a nutrient that bacteria like to have, and it also has antibacterial properties. We have immunoglobulin A, which is actually an antibody that binds to bacteria. We have enzymes that actually break down these bacterial or microorganism cell walls. So we have a lot of natural defenses in saliva, but saliva can go the other way, meaning that saliva can also be a breeding ground for bacteria. So saliva may have nutrients that bacteria actually like. So particularly if you have overgrowth of certain flora or certain bacteria, these enzymes can modify salivary components. um, you might have salivary proteins that can serve as a pellicle, or kind of the basis for attachment to something within the oropharynx. So saliva can be good and saliva can be bad. Also, it depends on saliva flow, and saliva flow is going to be very much altered in your intubated patient because they can no longer swallow, or they may be giving drugs that actually dry up that salivary flow. And when you dry the oropharynx, you create inflammation. So in general, these microorganisms are proliferating, and they're proliferating very rapidly, particularly in our critically ill patients, and they do need to be removed on a routine basis because they are rapidly forming colonies in the oropharynx, tooth surfaces, ET tubes. And so you have these pathogenic bacteria, MRSA, Klebsiella, Staph aureus, that can develop a biofilm, and this biofilm specifically in the oropharynx is known as plaque. So oral secretions, so the artificial airway and just the intubation procedure, saliva and swallow. So you can have salivary gland dysfunction just from the ET tube, mechanical irritation, nerve damage, reduction in sensation. We're suctioning out those secretions all the time, which we think is a good thing because, we don't want those oral secretions to accumulate and then fall down and go above the cuff. We have specific at-risk populations, these critically ill patients that are immunosuppressed, particularly our patients that are not just intubated for procedures, but they remain intubated because of critical illness. Secretion accumulation in the oropharyngeal and subglottic region, which we're going to get to in a minute, and then just plain access to the airway. Now, recently we've had a shortage of the Hollister, and so we've been taping our tubes. Taping is time consuming. We are not moving that airway as much as we used to. It used to be when we had the Hollister in place that we would just immediately move it to different stations within the mouth. Now, a lot of that was for pressure ulcer prevention, but it also allowed for ease of access to the oropharynx to be able to move that tube around and get to all areas of the oropharynx for both suctioning as well as oral care. And then you have your patient population and treatment. Patients may be receiving anticholinergic drugs, and you may have your neuro patients that have autonomic dysfunction. So let's take a look at intubation. So it depends, is it an emergent intubation or is planned? Obviously, emergent intubation is associated with a greater risk of aspiration. We don't know what their stomach contents is or are. And just in terms of, our DL or opening up that glottis, we're doing it emergently, and we may not be using the cleanest technique. It also depends on our pre-oxygenation. If we are bagging incorrectly, if we haven't opened up that airway, you might get air in the stomach that gives the opportunity for gastric contents to come back up. But even if we do everything right, probably some of those oropharyngeal secretions are going to fall back down subglottically. Gel lubricant can temporarily block secretions around the cuff for lubricating that ET tube before we put the ET tube in, and then awake intubation maintains the patient's reflexes. So we would assume that we might have less aspiration with that. Now, this study is looking at colonization in intubated patients there were 10 ICU patients that they looked at, and they evaluated the microbial profile at 12, 48, and 96 hours. The blue line is 12, the red line is 48, and the yellow line is 96. And you're seeing samples from both the oral mucosal, subgingival, as well as BAL. And so bronchoalveolar lavage. And the point here is not to try to remember all these pathogens and the lines. The point to see is that even at 12 hours following intubation that these oral flora are rapidly starting to increase. And you can see even more with both the red lines as well as the yellow lines, particularly in our BAL samples, which is C. And it's quite common to find that oropharyngeal bacterial DNA match what we see in BAL samples and match genetically the type of microorganism that we're seeing in VAP. So the reason that this overgrowth is a problem is because when you have this overgrowth, these bacteria will release enzymes that break down salivary components. They can then release these nutrients that the bacteria are like yum yum, and they can also alter the antimicrobial properties of the saliva so that it is going to be less useful in fighting both enteric and introduced pathogens in the patient. Now, our elderly population, which is a lot of our ICU patients, and when I'm looking at our ICU census recently, that's what I see. I see a lot of elderly patients. And this was looking at clearance of radio-labeled serum albuterol. And you can see all the bacterial isolates from the buccal mucosal. A lot of these probably look familiar in terms of the types of pneumonia pathogens that we see. But what they showed was that a lot of these elderly patients had reduced clearance, and this reduced clearance was associated with a higher level of pathogens and fewer normal flora. And so that biofilm, it can really protect bacteria from, say, an antiseptic fluid. So you really do need some sort of mechanical action to release that. So what is biofilm? We're going to take a look at it, but biofilm is extracellular substances like polysaccharides, proteins, lipids, nucleic acids, that kind of thing. And that biofilm starts to form rapidly, almost immediately within the oral cavity following intubation, and also in and around the ET tube. So we often think of the inside of the ET tube as having all that biofilm, but that biofilm is also forming around the ET tube, and a significant portion of that ET tube also remains within the oropharynx and above the glottis. So I mentioned anticholinergics and oral care. So there is something called the anticholinergic burden, meaning how strong is the effect that a drug might have in terms of their anticholinergic properties. Remember, anticholinergic drugs act on acetylcholine. And so different medications have possible, probable, and strong anticholinergic effects. And particularly if you start adding drugs up that have different anticholinergic effects, and those anticholinergics are going to cause a reduction in saliva flow or xerostomia. They also lead to long-term use in particular of drugs that have a pretty high anticholinergic burden. You can get dysphagia or a swallowing disorder. That dry mouth leads to inflammation and bacterial colonization within the mouth. Eventually you'll get periodontal disease, and it can also affect taste as well. So anticholinergics can be a big problem when it comes to oral care and the microbiologic load. These are some examples of anticholinergic medications that are used primarily to treat a disease, but there are also medications that have a byproduct of anticholinergic effects and can dry out the airway. There's also autonomic dysfunction, which we frequently see in stroke patients. So the parasympathetic nervous system and the vagus nerve offshoots have cholinergic facilitation that can cause bronchoconstriction and mucus secretion. And we see this in the study of stroke patients. It was 19 patients that had stroke, and they looked at the onset of copious secretion, and which is known as bronchorrhea, and about 80% of these patients had an onset of increased or copious secretions within 3 days, and frequently these are treated with anticholinergics. And so you have to watch it. On the one hand, it's reducing secretions that could potentially fall down from the cuff. On the other hand, it's going to dry out the oropharynx, and in some cases, it can actually plug the patient. Now, we think that maybe our cuff is providing some kind of protection. Again, we know that these pathogenic microorganisms start to appear pretty quickly, and that ET tube disrupts our normal anatomy and defenses. But there is typically going to be a leak around the cuff. So cuff inflation during invasive mechanical ventilation does not prevent microaspiration because there are folds in the cuff. You can have variations in pressure. So when a patient peak pressures, maybe the cuff pressure you have set at that moment is working, but if you have higher inflation pressures from those higher inflation events, maybe it is not. And then you have aspiration that may occur with the inflated cuff. The trach may impinge on the anterior portion of the esophagus, and it can prevent a normal swallow. A lot of our long-term trach patients have developed some type of airway abnormality like tracheal malacia, and frequently you have trach malfunction. Oftentimes, these trachs are not changed. The life of a trach is about 29 to 30 days, and our ENTs are telling us that they just don't have time to change these trachs, and so the cuff may not be functioning fully. So even fully inflated cuffs may still allow the leak, and most of these ET tube cuffs are barrel shaped. And I think this picture is pretty self-explanatory, and this is showing the way liquid can kind of penetrate around the folds in the cuff. There may be secretions above the cuff, and this was a patient that had a tracheostomy with subglottic suction, and you can see that picture of the right, how just the volume of secretions that we got out of this patient. And actually, I got out 2 syringes from this patient, and then I applied a low level of continuous suction and got out even more from this patient. So you can just imagine all that was raining down with potential microbes to this patient. Looking at the pilot balloon, examining the pilot balloon, whether you're feeling it or you're visualizing it, really doesn't tell you much about whether what your cuff pressure is or whether you have adequate cuff pressure. I did play a little game with our staff called Guess the Cuff Pressure by looking at this pilot balloon. Initially, this cuff pressure was 44, and when I measured again, it was 34, just because the act of measuring actually draws off volume from your cuff, and it can create a leak. Measuring the cuff pressure can create a leak that then allows secretions to rain down into the oropharynx. And like I said, it's inaccurate for determining both cuff pressure and seal, because some people were like, it's 60, some people were like, it's 20. And it turned out to be, most of the people were wrong. And again, these cuff manometers can actually cause an air leak, and we tend to lose them quite a bit, and they may be cross-contamination. Just keeping in mind that any kind of movement, almost any change in patient position, patient activity, airway pressure is going to change your cuff pressure. If you look at the graph above, most of the time, so we're shooting for that blue line of 25. But most of the time, when you have some type of movement with the patient, which is what you're seeing here, it's going to increase cuff pressure. Occasionally, it does decrease it. We're usually shooting for a cuff pressure between 20 and 30, below 20 microaspiration, above 30 ischemia because of capillary filling pressure. And this crazy graph at the bottom is really just showing that you can't predict what cuff pressure is going to do for any individual patient, which is each of these lines is an individual patient, based on their change in position, that it really varies. And then this ET tube biofilm. So 95% of these ET tubes have some biofilm formation that has, pathogenic microorganism growing. And you're seeing that whole matrix there, which is combined with those polysaccharides or starches that really make this biofilm adhere to oral surfaces. And that biofilm, its development and continued release, really explains a lot of our multi-drug resistant organisms and VAP that is just not responsive to treatment. And a lot of it is associated with these gram-negative microorganisms of Enterococcus, Staph aureus, Klebsiella, Acinetobacter, Pseudomonas, etc. So that biofilm really needs to be disrupted through oral hygiene methods. And toothbrushing is probably the biggest one, that mechanical removal of plaque to get rid of the primary source. But you can't just dislodge it and disrupt it. You actually need to remove it through rinsing and through suctioning, because then you can get that translocation of bacteria. Sort of a newer approach is also getting rid of that tongue coating. And that tongue coating consists of a lot of microorganisms, desquaminated epithelial cells, blood metabolites. And all of this is affected by oral hygiene, as well as the patient's clinical status and any medications that they take. And in this study, they were looking at toothbrushing plus tongue coating versus toothbrushing alone on this tongue coating. And they showed that by cleaning the tongue or scraping the tongue, you were really able to get rid of more of that tongue coating than just toothbrushing alone. So this looked at tongue scraping and oral pathogens. It was a prospective observational study looking at ICU patients that were the control group and palliative care patients that were the study group. It was about 50. So in the control group, they did a one-time sample of oral pharyngeal area as well as some tracheal secretions. And in the study group, which was the palliative group, they did different time points. They did within 5 to 7 days, and they also took tracheal samples. And what you're seeing here with all these different microorganisms is that when a patient arrived to the ICU, they had a lot, or at least many samples that were positive for potentially pathogenic organisms, kind of showing that that oral care is often poor in these patients and precedes their admission to the ICU. In the study group, they really didn't find that tongue scraping reduced the number of aspirates that had pathogens in it, but what they said was, and what the authors concluded was, that that frequent tongue scraping was really necessary in order to control that load, because again, these patients were coming into palliative care already colonized with these pathogenic microorganisms. And so it's imperative to, on a consistent and daily basis, try to get rid of them and try to reduce that bacterial load. And this was 30 subjects in a Brazilian CCU that had a diagnosis of VAP, and you can see all the different microorganisms there, pathologies there. And they found the same bacteria in dental biofilm. 63% of them were in the tongue samples and 73% of them in the ET tube. And again, so even though we're thinking of VAP and we're thinking of intubated patients, we need to be thinking of patients from their entire length of stay, and regardless of whether they are in general care, intermediate care, ICU. And this was a blinded crossover study in 19 patients. And so they did a home intervention where they were looking at toothbrushing along with scraping of the tongue. And they found a significant reduction in biologic load from baseline when tongue scraping was added. And so you have your different interventions. And here, when you're looking at intervention 1, that's toothbrushing, intervention 2, toothbrushing plus tongue scraping, and intervention 3, toothbrushing, tongue scraping, as well as a suction apparatus. And so you can see interventions 2 and 3 both reduced the load, but intervention 2 in particular really reduced microbiological load compared to baseline by a factor of 2.5. And so that was toothbrushing plus tongue scraping. And so again, just a reduction from baseline, and you can see 1 is toothbrushing, and then 2 and 3, you added both the tongue scraping and the suction. In terms of risk factors for VAP development, so this was a study that was looking at the odds ratio for developing VAP in MICU if you had a coated tongue. And so they were showing that the odds ratio was about 1.69 times for the development of VAP when you had a coated tongue, which is quite significant. And so that VAP risk went from 20.4 versus 13.69 in the adjusted analysis with a coated tongue the first ICU day. So again, these patients are coming to us already with a coated tongue, which makes it super important to try to implement some type of oral care to reduce that. So what are some of the benefits of tongue cleaning in the elderly, which again, a lot of our patients are? I mean, it's related to tongue function, which is related to swallowing. So we know the tongue forms the bolus, it propels the bolus, both orally and pharyngeally, but mechanical stimulation through tongue scraping can actually cause some improvements in these patients through mechanosensation. It improves proprioception, which will provide the brain with information on the tongue's position, movement, pressure, texture, oral awareness, bolus characteristics, stimulation of certain reflexes as well as sometimes cortical reorganization when combined with exercises that can help remap for stroke patients. And so kind of taking all this evidence, we look at our bundled protocols, which is what we're using in our hospital now. We use oral assessments, toothbrushing, mouth and lip moisturization, along with secretion removal, because you can't just loosen it. You actually have to remove it, which is sort of the normal mechanism of saliva flow and your swallow or spitting out during toothbrushing. But because data shows the possibility of increased mortality with chlorhexidine and the failure to prevent VAP versus toothbrushing, along with the potential for problems with chlorhexidine, we go with only toothbrushing. And I don't know if this picture of our standardized order came out very well, but you know, we do what is included in this bundled protocol. There is variability, though, amongst institutions and their bundle components, the adoption, rate of de-adoption, meaning they no longer use chlorhexidine. But in general, I think a lot of institutions have moved away from it to just toothbrushing, and maybe there needs to be a few additional things that are added as well, including tongue scraping. So in summary, ventilator-associated events and VAP have very clinically significant important events that are meaningful to the patient and meaningful to the hospital as well, including prolonged hospitalization and mortality. The updated 2022 guidelines for VAP prevention show that oral care is deemed an essential practice in oral care with toothbrushing, not chlorhexidine. Studies included in the Cochrane meta-analysis showed that toothbrushing decreased VAP and that chlorhexidine was not better. And some other studies showed that chlorhexidine may increase mortality. There was unfortunately no data comparing selective digestive decontamination or oral decontamination versus toothbrushing for important clinical outcomes. So we can't really draw any conclusions there. We know that intubated patients are at risk for VAP, secondary to alterations in natural defenses, and that these colonies form very rapidly, and we have insufficient protection from our cuff. Even if we have an adequate cuff pressure, there may be folds in the cuff that allow the microaspiration of subglottic contents. Toothbrushing mechanically removes plaque, and tongue scraping is something to consider because it can, as we saw in some of these other studies, reduce the microbiologic load compared to just toothbrushing alone. So now I'm going to turn it back to our moderator, Lexi Caraway, to see if we have any questions. Thank you.
Thank you, Gail, for that very informative session. I would like to inform our viewers how they can obtain their CEs for this session. This activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging on to www.saxtesting.com/T. You will need to register on the test site and then complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an education grant from Dale Medical Products. An archive on-demand version will be available on www.perspectivesinnursing.org. The on-demand version will be accredited for CEs. And now we had a lot of questions from the audience, actually, Gail. So I've got a few picked out here. We probably won't be able to get through several of them. So can you provide any information about chlorhexidine and the increase in mortality with that, the use of that?
Yeah, I think some of the theories are, but I don't think that there's anything that's proven, is that it can cause lesions, it can cause like disruption of cells within the mucosa, which can cause transmigration of these bacteria to different areas. I know there's an association between bacterial infections in the blood and poor oral health as well. There may be aspiration of chlorhexidine, which one author proposed might actually cause lung injury. There may be antimicrobial resistance that develops with chlorhexidine. So these are all just theories as to why chlorhexidine might actually increase mortality.
Okay, thank you. We had a few questions on this, so I do want to hit this one. How often is the oral care being done? Is it every 4 hours or every 2 hours, or what's preferable? Several questions on that.
Can you repeat that? For some reason, I didn't hear the question.
Yeah, it seemed like it cut out for just a second. Several questions on whether oral care should be performed every 2 hours, 4 hours, what's preferable?
So I believe that, we are looking at oral care based on our standardized orders of about Q4 hours in our patients. I don't think that there's any standard on frequency, in these patients, using the Bose scale, depending on your findings of the Bose scale, which is, the back oral evaluation of the oral mucosa. Based on what that score is, they're recommending that you do certain things at certain time intervals. So it may also depend, following that oral evaluation, how bad does it look, in other words, as to whether you may want to do it more or less frequently. Unfortunately, I can say that oral care is something that frequently falls to the wayside, and regardless of what our standing order is, I think we're often lucky if it gets done once a shift, really.
Okay, very helpful information there. And then this is going to be the last question, but there was some questions about, can you discuss how the tongue scraping and the suctioning works? And then who's responsible for this? Is it a shared responsibility between RT and nursing, or can you just give us a little rundown of that?
So typically the nurses do it in our hospital. I don't know if it's a shared responsibility in other hospitals, but the tongue scraper is actually, it's a device that has kind of a more solid edge to it, and you run it down across the tongue. It should be combined with like a rinse and suction, because again, once you loosen it, you can't just leave it there, because then you're going to disperse it, and you could disperse it into places that you don't want to go, including allowing it to be aspirated by the patient. So it physically scrapes and removes that biofilm on the tongue, and then you combine it with a suction component that actually gets rid of the biofilm that you have just scraped.
Thank you. So thank you for attending this webinar. I will now turn the presentation back over to Tracy for some concluding remarks.
Thank you, Lexi, and thanks, Gail, again. We also like to thank everyone for attending today's webinar. Immediately upon the conclusion of the webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. As well as for the CE Certificate of Completion, in 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. That's www.saxtesting.com/P. And again, we thank everyone for joining today, and we wish you have a great rest of your day. Thanks.
Thank you.